Welcome to Off the Record News. I'm your host, Diana Longrie. Thank you for tuning in. This program is brought to you live from the SEC studios out of White Bear Lake. And through cooperative agreement, this program is also simultaneously broadcast live to those studios out of the Roseville viewing area, the CTV studios. As a result of this cooperative effort, this program reaches out to and serves approximately 28 communities in the Northeast metropolitan area. So for those folks who are watching us on December 28th, well, please call in if you have any questions or comments for us this evening, because we'd like to involve you in our conversation on a very important issue tonight, and that is health care for all. Now, for those of you who watch us during other rebroadcast times in St. Paul, Monday night, 8 o'clock, we welcome you. And for those of you out of the Town Square viewing area who watch us on Thursday nights, 7 o'clock, in the Mendota Heights, Mendota, Inver Grove Heights, West St. Paul, and South St. Paul area, we welcome you on Thursday nights. Tonight, of course, we are going to be talking about an issue that you have heard some conversation about before in a number of programs over the past few years, and that, of course, is providing health care for everyone in America. A lot of people think that, well, because the Health Care Act was for health insurance reform was passed a while back, that this problem has been solved. Well, quite the contrary. This problem hasn't been solved, and it's going to continue to be a national crisis. And I have with me this evening Dr. Ralph Bovard, who is going to talk about this issue. He's a doctor, a medical doctor who's practicing in the field, and he's got a bird's eye view of what's going on with regard to medical care and health care for all, and the inadequacies of the system that we have and how we can improve it. So with that, I want to welcome Dr. Ralph Bovard. Thank you very much for being on the program with me tonight.
Thank you. It's a great privilege to be here, and I look forward to the opportunity to have a rousing conversation for an hour over this topic that's vital importance to all of us.
Yeah, and you know, I like the fact that you use the word a rousing conversation, because that's exactly what we should be having here in this country, and certainly tonight at this table. And that's why I'm inviting our viewers to call in with questions and comments about this, because we should be having a rousing conversation about this very issue.
Exactly, and I felt very strongly that one of the really crucial things is that this should not be a partisan issue. The topic of health care is something that's so important to all of us, and to you know, our families, our children, our parents, and yet we've let it become divided by our politics. Mm-hmm. And I think that it's really crucial that we look at this as an issue of fiscal responsibility, and look at the ways that we can make this a win-win deal for all of us. Mm-hmm. And the examples exist in every other industrial nation in the world.
Right. And I think it's really important to note, certainly from my perspective, being a practicing attorney, I see many examples of reasons why people find themselves not able to work. And a lot of times it's because of health care issues, that they maybe didn't have the health care that they needed when they needed it, or that they don't have the health care they need today to take care of the problem. And so then they become unemployed, they are not able to take care of their families, and it really does make sense that if we were able to take care of these issues up front from the very beginning, it would really help for making sure that we have, you know, a more healthy workforce, a more healthy family structure, and would really, I think, at the foundation of who we are, help us be a more productive country.
Right, and one of the things that's confusing as well is that even though with the Affordable Care Act, or the Patient Protection Affordable Care Act, which we call PPACA, increasing healthcare coverage to approximately 25 million Americans, we're still going to be left with upwards of 25 who will not still have care. The difficulty is that there are so many Americans who are underinsured, or even if they have insurance, if they become seriously ill and lose their employment because of illness, then lose their health care and can become bankrupt. And one of some of the really revealing studies have shown that upwards of 62% of all bankruptcies in America at this point are due to medical issues. And of those, 75% of people had health care insurance prior to becoming ill. So it really is an issue where nobody is spared the threat of bankruptcy in America because of serious illness. And that doesn't occur in any other country in the world that has a universal care system.
Right, and you know, talking about that aspect of the financial aspect of it, I do know some individuals that because they maybe lost their employment or that they're self-employed, that they didn't necessarily have health care. They went and they got a plan, and then to help pay for it, they put it on their credit card. Well, of course, that's no way to fund your health care either, because once you reach that limit on your credit card, you can't pay for it, and then you don't have health care any longer.
Sure, and one of the things we're seeing, there are various tools that have been devised to try to help people with care, like healthcare savings accounts and things of that sort. But what we've seen with those is that they actually work contrary to the notions of preventive healthcare and and ultimately to wellness. People tend not to get the preventive care they need because of deductibles, co-pays, those sorts of things.
Yeah, exactly. Now I'm thinking to myself, you know, my viewers out there are probably thinking, well, who is Dr. Ralph? You know, what does he practice in? What's what's this guy about? Maybe, you know, introduce your background a little bit to our viewers, and then they'll probably get a really great perspective of where your comments are coming from.
Well, I'm 59 years old, so I'm a little bit of old school. I was in the transition period from a time when most physicians would actually maybe do an internship and then grandfather into a particular area of practice through an apprentice or experience, essentially. My work history in the past has started out in emergency room and then has been primarily musculoskeletal medicine, non-operative orthopedics and sports medicine and occupational medicine. So I've had a real smattering of patient mix and patient populations, and I think it's given me a good opportunity to treat and work with patients of all sorts of, with all sorts of problems. I've had the privilege of working overseas in Papua New Guinea and Antarctica and Asia and some other countries, and to see what it's like there as well. And I've had injuries while competing in sports in England and in Canada, and so I've had the opportunity to be a patient in those countries, and basically my entire care for 2 or 3 visits was, I think, $5.
Oh, my goodness.
So.
Well, see, and I think that that's really important that, that the viewers see that you have a very practical view of what the healthcare system is all about, because so oftentimes people are watching TV and they see the theoretical talking heads just talking about it in theory. They're not actually practicing medicine every day. They're not working with patients every day. They're not trying to work with the bureaucracy every day. And I think that really helps to bring it back to ground zero when you're talking with somebody who actually is in the trenches working every day with patients.
Right. Well, I think, and I think most of my friends and colleagues would agree, I think that we still have absolutely superb health care in America. I think that the quality of the medicine that is provided in the United States is excellent. It's I guess our bone is with the system that's run by private business and by the insurance company largely.
Well, the accessibility of it.
Right.
That's not necessarily accessible to all. We may have very good health care. We may have very good procedures and very good mechanical devices and very good medication, but it's the access and the ability to be able to access that and to afford it.
Yep. Yeah.
Yeah, exactly. Now, of course, our viewers out there are probably thinking, well, gee whiz, what exactly are they talking about? Well, we're talking about right now that currently we have a model that uses private insurance companies as the model for being able to provide health care insurance to citizens who buy their product, and that there are many different products throughout the market, and it's very hard to compare those various insurance companies and the product that they have to offer, and that loss ratio between what part of that dollar goes to medical costs and medical care, and what part goes to administrative. So what do you see from your perspective of having to deal with all these different insurance products and how that impacts the patient?
Well, that's I think any patient who has called and tried to deal with billing and coding issues has run into this barrier of insurance folks that they need to get through the line to and get authorization for procedures or treatment, or arguing bills and things of that sort. And one of the subtle ways of rationing in America is the denial of care by the insurer, and part of that's because they make a profit by paying for less care. One of the terms that's used now is the medical loss ratio, the MLR, and that's typically in the United States right now it's about 80%, which means that the insurance company is obligated to use 80 cents on the dollar that they collect as a premium to pay for health care. They actually consider that their, well, I mean, it's their loss, and it's our care. So, and of that 20%, there's actually an additional approximately 10% that's additional administrative costs that often occurs in running a doctor's office or the hospitals. One of the things that I find real striking is that when you break down the pie chart of where all the money goes in healthcare nowadays, about 38% of it's to hospitals and hospital costs, 20% is to 20 or 22% physicians and caregivers, about 10% to for drugs. But the actual portion that's administrative costs, and that includes insurance company profits, is about 30 to 31%, which means that of our $2.7 trillion healthcare budget, we're spending $750 to $800 billion per year to allow the insurance company to continue to run our healthcare system as a for-profit system, and is largely money that we would save. We could drive our costs down certainly below 10%, which would be a huge savings and allow us to insure and cover everybody.
Right, and I think you brought up a very important point that the viewers should come away with, is that there is this issue that there are other models, and that this is an a private insurance company model that hasn't necessarily worked to the best benefit of the patients, because the money isn't necessarily going as much to health care of the patients as if you used a different model like single-payer health care.
Right, and there's some buzzwords that the insurers tend to like to use, like patient-centered care, transparency, consumer-driven, those sorts of things. And the reality is that the things that they do are, for the most part, the antithesis of that. Right now, people talk about the invisible hand of the marketplace, and I look at it as more of a claw. I think that it's proven to be a lie that competition will make healthcare cheaper, and I think we've seen that for the last 30 years. It doesn't. And it works quite the opposite.
Right, and I think for a consumer, it's very difficult to compare the different health insurance companies because they have different ways that they operate. They aren't transparent in how they operate or how they're structured. And so a consumer, if you're looking at it from the perspective of consumer driven, they're not necessarily able as a consumer to even make an informed consumer decision, or they're unable to because their employer or their union has already decided who they are going to be with. And so there really isn't that much decision for the consumer.
Yeah, it's very, very difficult. And even as a caregiver, I have a very difficult time unraveling the intricacies of the system, and when I've been a patient to try to sort through things. One of the things that I had not honestly been aware of until about 5 years ago was that there are actually healthcare brokers who every year are out there approaching small businesses primarily, trying to convince them to change their healthcare plan from one to the other. In Minnesota, we have roughly 5 or so. And what that means is that the people who are insured within a company have the likelihood that they may be bounced from one caregiver or one insurer to another every year or two for the promise of some better premium or some options. And what that does is actually promote discontinuity in care because systems typically have different electronic medical record systems. And what happens then is a patient goes in, their records are no longer where they're being seen. The physician may have to order additional tests at additional radiation or additional costs to try to solve the medical problem. And so it's a very difficult situation that we have this fragmented system of over 1,000 or more insurers, and all of the CEOs of each of these companies makes millions of dollars.
Right, exactly, exactly. And I think that that's the one point that I think the commercial media is getting out there, is that the salaries of the CEOs. At least that point's getting out there, but that's about it.
Certainly the non-profits here in Minnesota don't make the obscene salaries that the private insurers do, like Aetna and United Health Group and that, but it's still significant. And I think that, you know, the fellow who was the head of the VA nationally had maybe a $300,000 to $400,000 salary to run the entire VA system, which is a system that has a single electronic medical system, record system nationally. It's portable and has the top-ranked satisfaction ratings of all healthcare in America.
Right, exactly.
So.
Now I understand that we have a caller on the line. Should we invite them to the table?
Absolutely.
Okay, excellent. Okay, caller, thank you for your patience. Questions or comments for either myself or my guest this evening?
Hello, Mayor Longrie. Excellent show tonight. The question I have is about about the politics of it, because it seems like the politics is what healthcare is all about. In the Republican field there, whether you're talking about Ron Paul, who's a physician, or Santorum, who's a physician, or Bachman, whose husband is in the medical industry, they're all against the Affordable Health Care Plan, which was the Democratic plan, which apparently is the uniquely American system where you enrich health and care and insurance companies and executives. My question is, I listen very carefully and I never hear what the Republicans' ideas is, whether it's the presidential candidates or the members of the Congress or the U.S. Senate candidates. Do you know what the plan is, which the Republicans are pushing on the federal or on the state level? Thank you.
Okay, thank you very much for that question. I think the caller is getting to the point, well, what's the alternative? I mean, you hear that, well, certainly with the legislation that was recently passed at the national level, a lot of Republicans are unhappy with it, but what's their alternative? Certainly it's not single-payer health care.
Right. Well, first off, I guess I would say that I think this has been I wouldn't blame the Republicans solely for the dilemma that we're facing. I think this has been an issue that all of us as Americans have been complicitous in terms of permitting. The Senate Finance Committee that basically spearheaded the PPAC arrangement was headed by Max Baucus, who's a Democrat from Montana, my brother's state, and I love Montana, but he has vested interests with the healthcare industry as well as other members on that committee. So again, I think it's just so vital that Americans of all dispositions and political persuasions look at this as from the standpoint of an issue of a moral issue, and also as a fiscal issue, that from a budgetary standpoint, if a person looks at the numbers and compares our system with that of every other OECD nation, all the top westernized industrial nations, they'll see that we're paying roughly double what any other nation does, and that's largely because we've allowed the insurance industry to mandate how we deliver care.
And when I think you look at it that way, then the ultimate question is, why would we want to pay almost double? I mean, think of how much more you could get if you weren't paying double.
Yeah, well, and the bottom line is that we need to boot out the fat cats, and that's kind of what it boils down to. And we can then, I think, have the quality of care that and the care that would cover everyone in America. And I really think that Martin Luther King had a great quote to the effect that that of all the forms of inequality, that injustice in healthcare is the most shocking and inhumane. And I think that's really true. And I think the issue of the social gospel and what we as a nation have stood for many generations supports that notion. And I think it's time that we, as a people, held our politicians' feet to the fire. And we pay enough already by almost double to have the care that other nations have, and by rights we should have it.
Exactly. Now we have, you've brought along with you a few charts that I think really help to demonstrate some of the numbers that you've been talking about, and we can go through a few of these but kind of talk about what they depict and what they're talking about as well. So we'll flip to camera one so then we can take a look at this. First one is the healthcare spending per capita. Exactly what you were talking about, how we're spending nearly twice what everyone else is, and that top line there, well, that's the United States. So here we go. There's the graph, exactly what you were talking about.
Well, it's and I think the striking thing is that if one compares a graph of the United States healthcare expenditures with those of Canada, for example, that our trajectories were very similar up until about early or the late 70s, when Canada really enacted their universal care system. And they've diverged since then. And also during that time, we have a graph in here that shows the increase in the burden of healthcare administration in America that parallels that as well.
Exactly. Now, if I flip to the next page here, we've got another graph here, and this is healthcare costs as a percent of the GDP. Tell us a little bit about what this shows us.
Well, it helps to indicate the fact that, again, the United States and Canada were on very similar patterns, and then about 1970 or thereafter, our capitalized system sort of ran amok. And I think we're seeing the consequences of unregulated capitalism. We've seen it in the prime mortgage industry, the banking industry, and finance, and I think we're seeing it in healthcare now, and it's going to get worse. And I think it's the notion that people need to think about, that capitalism does not equal democracy, and that the notion of pooling resources for the good of the common people and for all of us, that's what democracy is about. That's not socialism. We pool our resources for police care, for fire care, for our public services, for our military, for everything else, and no one calls that a communist takeover.
Right. Well, and I think it's a very important point and distinction to be made, is that when you're talking about socialized medicine, at least to my understanding, is that socialized medicine, it means that the doctors and the healthcare providers are actually employed by the government. And with single-payer healthcare, that's not the case. That the doctors and nurses and healthcare providers, they still are self-employed or working for clinics or working for hospitals, separate individual entities. It just happens that the way that they're paid is paid from one money pot that everybody is paid into. And so that's really what the difference is. And so a lot of times when people start this conversation, they start claiming, oh my goodness, we're talking about socialized medicine. And that's not what it is, because the doctors and the healthcare providers still remain independent, and that they work for who they work for, or they work for themselves. However it is that they are arranged, correct?
Yes, you know, a lot of it really is just semantics and terminology, too. Again, the VA is essentially socialized, and they have the most, or the top healthcare ratings in America. The physicians who work there love it. They have great success. Their patients love being there. England is essentially a socialized type system, because in the way it's termed, their the funding comes from a tax base, and so that's sort of the definition of being socialized. And yet in Canada, again, it's the funding comes from both the federal and the provincial level, but the administration is private. And the different types of systems, whether one calls it single payer or multi-payer, which is what Germany and France have, there's still a provision of funds from the people that then goes into a protected fund, or a central source that cannot be, that's inviolate from the government or the president or anyone getting into it. And so it's there to serve the people.
It's a dedicated fund.
Exactly.
And I think there again, people say, well, you know, yeah, but we see what happened to Social Security. It was supposed to be a dedicated fund, and so what did they do? They go and they rob it every once in a while, right? Yeah. And they don't pay it back. But I think that that's where it's really critical then, that the citizens say, you know, to their elected officials, when it's a dedicated fund, it's a dedicated fund. You can't just rob it, because it is for the good of everybody. And it's a contract that they have with the people.
Right. There's much more accountability. I mean, essentially, it would be, healthcare would be run like our fire departments, like our police departments. There's local and regional control, and there's much more transparency than we have right now with big business. I mean, again,
you know, that's a great point, because this has been an issue here in Minnesota with regard to the HMOs that are receiving state funds to take care of, like Minnesota Care, is that they don't disclose how the money's being spent. However, I could see where if indeed we had single-payer health care and you had this pot of money, it's dedicated for how it's being spent, it would be subject at the federal level, certainly to the Freedom of Information Act. And the citizens actually would have that right to that transparency to know what was going on, whereas you can't go up to your local you know, health partners organization and say, hey, I want to do a data practices request, or I want to do a Freedom of Information Act to see how you're spending my insurance premium. You just can't do that.
Well, that's true, and there's approximately $3 billion a year that's in tax-based funding that's channeled through our not-for-profits here in Minnesota, and there really hasn't been accountability or disclosure in how they administer that and what their profit is from it. We know that they have about $1.6 billion in reserves, which is far in excess of what they would need in terms of, you know, funding. Dave Feinwachs is someone locally who's been trying to unravel some of that.
Yeah,
And,
exactly. I think that's very fascinating. And now we have another chart up on camera 1 that we could take a look at. And this is what you were sort of describing earlier about that difference between the growth of physicians and the growth of administrators from 1970 to 2009. And, well, the physicians is the little tiny yellow line underneath here, and then, well, this whole big blue mountain here are the administrators. Wow. So what impact does that have on healthcare today in America?
that's just the convoluted nature of this gargantuan healthcare industry that we've allowed to grow. And for example, at Mass General, they have whole floors of people, and that's all they do is accounting, administration, and coding and billing. It's said that in Toronto, that a hospital the same size has about 3 people who do the equivalent job of billing. So.
That's incredible. And earlier you mentioned the importance of semantics, and I couldn't agree with you more. Because so oftentimes it seems that when this discussion is coming up, everyone has the semantics that they want to use to try to either get people to rally for or against, or somehow to strike at their emotions. And I found back in 2010, when I was running for Congress, that I found that it was more important to talk about what it was, the benefits and how it operated, and asking people about what they were looking for in their healthcare system without using labels. And it was amazing that you could find almost universal agreement among almost everybody I talked to, and it made no difference what party they were, that they wanted to have a healthcare system where they had access, where it was affordable, where they could pick their own doctor, where their medical decisions were being made between themselves and their doctor, and that those administrative costs was kept in the range of 5 to 3%, 3 to 5%. And universally, almost that's what everybody wanted. And yet, if you then start putting labels to things, suddenly a group of them would say, oh no, we can't have this. That would be terrible. But yet, if you'd only talked about how it worked and its operation and its structure and the model, then suddenly everybody was pretty much on board.
Yeah, I think that's one of the real frustrations, for me at least, in that the benefits and the cost savings and the patient benefits of a single payer or a universal care system are so overwhelming. And I think that if anyone is able to honestly look at the systems of other nations, major nations who have the same kind of problems we do, put their pants on just like we do, like Britain and the Scandinavian countries and Germany and France and Australia and Canada, that they would see the value in this, and yet American people seem to work against their own best interests, and I don't understand why that is. And it's one of those things where I think sometimes you develop an allegiance to a concept or a party affiliation that just becomes knee-jerk in its reaction. And again, that's why I think it's so crucial and important that we make this a nonpartisan issue, and we really appeal to the fact that, we all have parents and we all have family members, and we all want them to get the best care. And my dad is 84, and my mom passed away this summer, and I don't want my dad to lose his Medicare. And it infuriates me that there are medical groups out there that run his Medicare through their company and automatically bump the cost of it 10% for their profit and give him nothing out of that, and it's my taxpayers' tax dollars that get jacked up for it.
Exactly.
And I think everybody should be outraged by that.
Yeah, exactly. And the fact that it could operate just fine without going through that middleman.
Exactly.
And I think that's the whole point. And oftentimes when I'm talking to folks, especially if whether or not if they're employed and that they have their health insurance through their employer or maybe even an employer, where they say, well, this would just add on another cost. Well, but the point is that it's actually a replacement for the health insurance premiums that everybody is already having taken out of their paycheck already. And that actually, if they were simply to increase that payment that would go to this overall big kitty that everybody would tap into, similar to Medicare, that then it would be each person, if they wanted to buy a supplement, they could, but they may not necessarily have to. And so suddenly then it's keeping and the employer's costs down to be able to be competitive with other employers out in the market, because you've got a more level playing field with the type of medical benefits that you have to offer. And for the employee, they may actually find a realization of more disposable income in their paycheck because their premiums are less.
Right. Essentially, for allowing the insurance industry the privilege of administering our care, I mean, essentially, in total administrative costs, runs us almost the equivalent of what the TARP bailout was. And so we're giving that to the insurance company, about $750,000 every year. And not all of that is their profit, but it's administrative costs.
Sure.
And, you know, the people complained that the Obama plan, which was not anywhere close to what he originally wanted, but was going to cost nearly $1 trillion over a decade. The reality is that we're going to spend upwards of $35 to $40 trillion on health care in the next decade. So spending 3%, $1 trillion to, you know, enact something new that's better makes a lot of sense. But in this case, we're giving away nearly that sum to allow the insurance industry and the private industry to, you know, deny us care and to increase the likelihood that any one of us could be bankrupt.
Right, exactly. So. Now on camera one, we have another pie chart here, and this is talking about the drug company's cost structure. So maybe you could tell us a little bit about what this is showing to our viewers.
Right. One of the things is that right now the pharmaceutical portion of our total healthcare budget is about 10%. So about 10% of $2.7 trillion, $270 billion goes to pharmaceuticals. So it's a huge industry, and that's the donut hole of most Medicare and the PharmD part. But this graph demonstrates or helps to, I think, show that that there's about a third of all the pharmaceutical costs are for marketing and sales. They tend to want to make us believe that our medications in America are highly expensive relative to the rest of the world because of research and development, R&D costs, and the reality is that's not the case. It's,
right.
It's a huge marketing budget.
Yeah, exactly. And I think this is this pie chart really is great because you hear so much about how what percentage, you know, that the huge percentage is going to R&D and testing and all of that. And really, when you look at the pie chart, it's only 27%. And that's really not anywhere near the 35% for the marketing and advertisement to sell the product and to administer, you know, how it's being sold.
There's a great smoke and mirrors game going on, and it's tough for any of us to understand and to see a lot of what is going on behind the scenes, but it takes digging. But people who I think dig into it can understand that. Right.
Now you did bring along with you sort of a cute little political cartoon that we'll have to share with our viewers, and hopefully it'll show up on the screen okay there with camera one, and we'll take a look at that. And there you go, you've got the insurance company there in the middle, and you've got the patient saying, "Doc, can you see the problem?" And so the doctor's on the one side of the insurance company looking in the ear of the insurance company saying, I'm afraid so, trying to see through the head of the insurance company to see what's in the ear of the patient. You know, you couldn't find a more appropriate political cartoon that really demonstrates exactly, pictorially, what we're talking about.
Yeah, it's, we have no shortage of cartoonists with some great insight.
That's great. Now we also have another couple of pie charts here, again, that we can show on camera. One that show the Medicare HMOs high overhead and profits. Now we talked a little bit about this already, but go ahead and relate that to what this pie chart shows.
Right. Well, the big thing that I think this helps to demonstrate is that right now Medicare is actually a very efficient vehicle, and you know, the administrative costs are well contained. It's very efficient, and it's largely because they don't pay any profits to an insurance company.
And so, like for instance, this is the traditional Medicare model.
Right.
And then this is the Medicare Advantage plans.
Right. So this is once you funnel a Medicare plan through a private insurance company, you suddenly jack up the cost, and they need to take a profit out of it. And that was one of the issues with not including the pharmaceutical care in the original, or in Medicare, is that it left that loophole, and that's one of the ways that the insurance companies are going after that right now.
Exactly. Now we have a quote here on camera one once again, and this, go ahead and tell our viewers who this doctor is and really how she came about with this quote.
Right. Well, this is Gro Harlem Brundtland, who's one of my heroes or heroines, and she was the Prime Minister of Norway, and on, I think, actually 3 occasions. She was the director of the World Health Organization, and a brilliant person. She's a physician. Her father was a physician and studied in the U.S. for a bit. But I heard her speak over at the St. Paul Science Museum about 8 years ago, and she commented at that point that she felt that the United States in about 20 years would rue the day that they allowed the private insurance industry to take over our healthcare industry, or our healthcare. And I've always remembered that. It was something that struck me, and I think if you compare the healthcare in Norway or the Scandinavian countries with what we have in America right now, it was never more telling.
And of course, we talked about, with regard to the costs and the administrative costs that have added on to the cost of health care is one aspect of that. But earlier, you also alluded to another aspect of that, that the insurance company basically dictates and rations what medical care somebody is able to have, because they have their actuarial tables, they have their charts, they have their standards of what they want to be able to provide for what is planned for within their risk structure, not within necessarily what is the decision that's being made between the patient and the doctor. And I think, again, that kind of goes to, again, ruining the day that you let the private insurance companies, you know, be in charge of it, because, you know, who are they, based on profits, to decide what medical care somebody should have for their particular and individual condition?
Right, and right now we're faced with something that I think is even more insidious, and in what's called ACOs, or Accountable Care Organizations. And they're the new buzzword in healthcare. They were something that got its toe in the door when they were writing the PPAC, the Patient Protection Affordable Care Act. And again, this was something that the insurance company slipped in through the legislators. But really what ACOs are is a variation of HMOs. HMOs were shown to have been a failure and didn't do what they claimed they would do. The idea with ACO is that it actually allows major insurance companies to actually buy up healthcare groups and to create their own standards of care that allows them to then drive patients, or what they call consumers, selectively to certain caregivers based on the expectations that they have of those caregivers. And the caregivers are rated based on them performing the way that the insurance companies want.
I see.
So it's a very subtle and very deceptive way of steering healthcare. And the great irony is that it's completely contrarian to the very precepts that are pushed in terms of consumer-driven, patient-centered, and transparency, because it's actually very secretive. It drives the patient to the group that they want, and you know, it's
in other
deceptive.
words, it's bureaucratic-driven.
Yeah, yeah, and it's, you know, in Canada and the other countries, you can go to whatever doctor you want, but with ACOs, you won't be able to do that.
Wow,
you
interesting.
won't be able to do that.
Interesting. Now, I understand we have another caller on the line. So let's, caller, are you there? Questions or comments?
Caller, are you there? Questions or comments?
And you could turn down your...
Yeah, I'm here. Can you hear me, Diane?
I can hear you. Thank you for calling in.
I can hear you. Thank you for calling in.
I can't hear you, though, now.
Oh, that's okay. I can hear you.
Can you hear me?
Yes, I can. Go ahead.
I'm enjoying the sum and substance of your program, and I agree with everything that you said. However, you're missing one point that I want to bring out.
Okay.
As long as you have people in the Congress and in the Senate that are making $2-3 million every year on issues that are not outlawed because they're doing it. I just saw an article today on the TV where 3 senators and three senators in 3 years made almost $3 million, and you want them to vote for socialized medicine? Michelle Bachmann says that she's entitled to it because she's an employee of the government. She's a congressman, but nobody else should have it. Nobody else should get this privilege because she's a congressman. And until you get people that will vote on that, and you get these lobbyists out of there that are filling these people's pockets and giving them money so that they can be reelected, you will never see a change here in the United States, because profit is the wisdom of the world. Dollar signs is my God. Good night, Jeanette. Good night, Mrs. Gallagher, wherever you are.
Thank you, caller, for your comments. And that is one issue that we haven't really quite fully addressed yet, is that the impact of the special interest groups and the lobbyists on the decision makers, who actually are the ones who have the power to bring about health care for all in our country.
Sure, and that's, again, that's where I think that our electorate is so vital in this, and again, understanding this is not a partisan issue. It has to be something that people look at as a quality of life issue, and really there is a huge moral component, and there have been comparisons to this as not dissimilar to the women's suffrage and also civil rights. And I think there's a great deal of truth in those comparisons, that this is a moral and justice issue, and it's an ethical issue. And I think that we need champions, both at a state level and a national level, to help us move in this direction. On the state level, John Marty and Jeff Hayden are supporting their Minnesota health care plan. That's a universal care. Nationally, John Conyers has the bill 676 that promotes a universal health care. One of my great heroes of all time is Tommy Douglas, who is a clergyman in Canada, who was the Prime Minister of Saskatchewan, who created the impetus for their single-payer program in Canada. And it led to a domino effect, and all of Canada then saw the value of this, and Saskatchewan has adopted that. In 2005, 20 years after his death, he was voted the greatest Canadian of all time over Wayne Gretzky and people of that ilk. So
imagine that.
right. So I think that it's something that I think there really is a moral compunction to, and I think as a nation, it's something that we can rise to and be a better, be the beacon on the hill that we have always thus far tried to aspire to.
Right, exactly.
Yeah.
Now I understand we've got another caller on the line, so let's see what our caller has for us this evening. Thank you for calling in. Questions or comments?
Yes.
Go ahead.
Hello, Diana.
Hi.
Can you hear me?
Yes, I can.
Okay. I'm glad you're covering this subject. I think it's really important. And I think part of the problem is what the universal health care needs is a different name. Single payer, people just don't understand. And universal health care, they immediately say, yes, it's socialized medicine, and it's no good in Canada, and you can't get anything done. But one point I'd like to make is that part of the reason those of us who are buying our own health insurance are actually paying the bills for those people who don't carry health insurance. We are paying much higher medical bills, much higher doctor and hospital bills. And I know of an instance myself where a couple who have the means to pay to buy and will not, he was hospitalized for an accident and injury, and it was just a small one, but got a bill for like $17,000. Called St. John's Hospital in Maplewood and said, oh, I don't have any health insurance. And they said, oh, well, we'll adjust your bill then. He received a bill following that for $3,000. Mm. So, and he's totally equipped to pay. So those of us who are honest and buying our own, whether we can afford it or not, and it's not easy for me to afford it. So we're paying for the freeloaders, which is really unfair. And yes, everybody deserves health care. They really do. Mm-hmm. And I'm glad you're covering. I think this is a terribly important topic. Mm-hmm. Well, and when Dr. Bovar just mentioned John Marty, it struck a big chord because John Marty has been on the right side of things all along. And another person who's a friend of mine, Becky Laurie, was the author of Minnesota Care. Mm-hmm. So this is a terribly important subject. I'm glad you're covering it, and I hope more people will pay attention.
Well, thank you, caller, very much for your questions and your comments this evening. The caller brings up another good aspect of this whole issue is that, there's the folks who are going in who don't have the coverage. They go into the emergency room. It is a very expensive way to be delivering health care. And then, in the end, who pays the bill?
Right, and I think it's a great point. It's something that I think we're all sensitive to, and I don't think any of us like to see our taxes go to someone who may be shirking responsibilities or not trying to carry their fair load, and I think all of us acknowledge that. I do think that currently in America, the greatest entitlement group, however, is the rich, as opposed, and I don't consider myself part of that, and I think it's truly a 99.99. So it's a 0.00 or 0.01% of the population that we're looking at in that sense. But obviously, none of us like to pay taxes and not have our, gainful reward for that or to see other people not doing that. But I think that the issue of an even, balanced tax base that gives everybody health care goes a long ways toward providing the preventive care that helps prevent a lot of the more serious illness that we see down the road.
And I think it is important that whatever model we have, that it does indeed include preventative health care, because in the end that will keep health care costs down substantially if you're preventing the health issues first.
Absolutely.
And we've got on camera one, we've got in our last 4 minutes or so, we have a couple of other charts that, again, to talk about those dollar aspects of it. This talks about the prevention and how it saves money. So go ahead and describe this a little bit.
Well, it just helps to document the fact that by avoiding illness in the first place, by staying healthy, we save a lot of the costs. We call the end stage here salvage care, and the more that we can do to keep things on the other end, vaccines and the benefits of society, which again are largely socialized, the things that we've pooled our resources for in public health, water and sanitation, have actually done about 25 of the 30 years of extended life that we've had since 1900. So those are the great benefits. I do think that it's really important that we interweave a patient bill of responsibility with our patient bill of rights. People need to take responsibility for health to a greater extent than they are right now. I did want to real quickly mention, too, that in terms of waiting times in Canada, that's a huge misconception. Many Americans wait far longer for care. Here, a lot of times people don't get care at all. And many of those problems that people wait for are musculoskeletal things for which it's not an emergency. You don't need surgery tomorrow for a total knee, or I didn't need surgery for my shoulder repair, in a week. It's something that you can wait, and hopefully by changing your behaviors can affect as well. So.
Exactly. And in our last couple of minutes, we have one final slide that I'd like to show, a camera one, which talks about the financing of single payer. And so again, just quickly go through the summary of this for our viewers.
Well, I think the most important part of this to look at is the idea that the funding, no matter what you call it, whether it's a tax or a premium or an income diversion, is money that goes into a central fund that is protected and dedicated to people's care. And it's not something that then will be taken out and have politicians using for something else. And that's the idea, that it's funded and then can be administered either publicly for public health or privately through the caregivers in a structure that's virtually identical to what we have now, that wouldn't need to be changed.
Right. And essentially this is the pot of money then that when you go to your doctor, your hospital, or your other care provider, whoever it is, then that they submit their bill to be paid from out of that pot of money that everybody is contributed to. So that way you can have affordable, accessible health care for all. So we are down to our last minute or so. Any last words that you would like to share with our viewers?
Only that I really feel that this is something that's of vital importance to everybody in the country, and it affects all of us, from infants to the elderly, and it affects all of us regardless of our political persuasion or disposition. And I think that if we can put our heads together and approach it in that way, and honestly try to understand the other systems around the world, take the best that they all have to offer, that we can come up with a system that truly is worthy of the nation and of our great caregivers.
Yeah, very good. Well, thank you very much, Dr. Bovard, for coming on Off the Record News, and hopefully maybe you'll come back on again another time to give us some more insight and update on how things are going.
It's a privilege being here. Thank you.
Thank you. And to our viewers, thank you for tuning in to this episode of Off the Record News. We'll see you again next week. New topic, Bye-bye.
We're broad